As new evidence emerges, treatments naturally shift to incorporate the latest research findings. Treatments that were previously believed to be beneficial may actually turn out to be less effective than initially thought. Despite the evidence, it can take years for surgical practice patterns to change, especially if the procedure is a big moneymaker. This results in periods of time where unnecessary surgical procedures continue to be performed despite evidence supporting less risky and equally effective treatment options. In this video, we will focus on 4 commonly performed orthopedic surgeries you're better off avoiding. And stick around until the end to find out why surgical procedures that aim to fix structural causes of pain often fail in those with chronic conditions. There are 2 menisci in each knee: the medial meniscus, located on the inside part of the knee, and the lateral meniscus, located on the outside part of the knee joint. The menisci are crescent-shaped and act similar to shocks on a car, helping to distribute the weight and pressure across the joint. When torn, the healing of the meniscus is directly related to the blood supply, which can vary depending on the location of the tear. The outer third of the meniscus has good blood supply and can heal on its own, or in some cases can be surgically repaired, which involves stitching the torn edges together. On the other hand, tears that are complex or located in the middle or inner third of the meniscus are less likely to heal due to the limited blood supply. So instead of repairing the injured tissue, the surgeon removes part of the meniscus. This procedure is termed partial meniscectomy. The effectiveness of partial meniscectomy has been a topic of debate. Studies investigating the efficacy of partial meniscectomy for degenerative meniscal tears, or tears that occur due to normal wear and tear, are finding no statistically significant difference in pain or function when compared to those who receive physical therapy. While some studies have suggested that partial meniscectomy may be beneficial in certain cases, such as those with traumatic meniscal tears or in younger patients, the evidence is still inconclusive and not without its risks. A significant complication after partial meniscectomy is the development of arthritis in the knee joint. Because the meniscus plays a key role in distributing weight and pressure in the joint, when part of the meniscus is removed, it disrupts the natural biomechanics of the joint, leading to increased stress on the articular cartilage, which can accelerate the development of arthritis. Studies have shown that patients who undergo partial meniscectomy are at an increased risk for developing arthritis compared to those who do not have the procedure. This is even higher in patients who have larger amounts of meniscal tissue removed and those who have pre-existing joint damage. Younger patients who undergo partial meniscectomy are at an even higher risk of developing arthritis, possibly because they engage in more impactful activities that put additional stress on the already compromised joint. So not only are the outcomes likely to be no better than structured physical therapy, there is additional risk of compromising the natural, shock-absorbing ability of the knee, which can lead to worsening symptoms and need for more invasive surgical procedures, such as a total knee replacement. Subacromial decompression is a common procedure performed to address subacromial pain, also known as subacromial impingement. Impingement has been classically defined as a condition that occurs when the tendons and bursa in the space between the humerus bone and the acromion become compressed during certain shoulder movements. To address this condition, surgeons make a small incision in the shoulder and remove any bone spurs and inflamed tissue that may be compressing the rotator cuff tendons in the subacromial space. The goal of the surgery is to increase the space available for the rotator cuff tendons to move freely and reduce the likelihood of future impingement. Several studies have indicated that subacromial decompression surgery does not offer superior outcomes to conservative management, including physical therapy, in terms of pain relief, functional outcomes, or patient-reported outcomes in the long term. There are also multiple studies showing that subacromial decompression surgery is no better than placebo or sham surgery. These are simulated surgeries which involve the surgeon simply washing out the joint with saline or making an incision and then closing it without performing the intended procedure. Now, how does washing out a joint or not doing anything at all perform just as well as subacromial decompression? Well, the answer likely has something to do with the flaws in the objective of the surgery itself. The clinical diagnosis of subacromial impingement has been shown to be a poor clinical diagnosis, as it is overly general and does not accurately describe all the underlying factors contributing to the condition. In fact, studies have shown that many people with so-called subacromial impingement do not show any signs of tendon compression between the acromion and humeral head with arm movements. Additionally, other studies have shown tendon compression in those with no pain at all. So very often, it's less of a structural issue and more of a load tolerance issue. Despite subacromial decompression surgery being a common treatment for those with shoulder pain due to subacromial impingement, there are numerous other factors that can contribute to shoulder pain. Other factors such as rotator cuff weakness, poor scapular control, and muscle imbalances very often contribute to shoulder pain and dysfunction, which cannot be addressed with surgery. This is likely why physical therapy treatments, including manual therapy and strength exercises, are being shown to be just as effective, if not more so, in managing this condition. Knee osteoarthritis is a common degenerative joint disease that affects millions of people worldwide. It is characterized by the gradual deterioration of the cartilage that lines the ends of the bones of the knee joint, as well as other joint tissues such as ligaments and meniscus. Knee arthritis is more common in older adults, although it can occur in younger individuals who have a history of traumatic knee injuries. Arthroscopic knee debridement is a surgical procedure utilized to treat knee arthritis. The surgery involves inserting a small camera and instruments into the knee joint to remove any damaged or loose tissue and bone spurs. The goal of this procedure is to reduce pain and improve joint function by removing any tissue that may cause inflammation or mechanical symptoms such as locking or catching of the knee. A study took patients with osteoarthritis of the knee and randomly assigned them to receive arthroscopic knee debridement or placebo surgery. Patients in the placebo group received 3 1-centimeter incisions in the skin to simulate debridement surgery without any insertion of surgical tools. The authors found at no point did the group that received debridement report any less pain or better function than the placebo group. Multiple other studies also compared arthroscopic knee debridement to physical therapy and pharmacological management in patients with knee arthritis. They each found that while arthroscopic knee debridement provided some short-term improvement in pain and function, the benefits were not sustained over the long term. Even though there is some evidence that suggests arthroscopic knee debridement may provide some short-term benefit for the treatment of knee arthritis, it is very likely due to the placebo effect, as there is no long-term benefits to the procedure. Physical therapy and pharmacological management has been shown to be just as effective in managing knee arthritis compared to those who receive debridement, while offering significantly less cost and risk of complications. Degenerative disc disease is a common condition that affects the spine, specifically the intervertebral discs that separate and cushion the vertebrae. As we age, the discs in our spine can degenerate, losing their ability to absorb shock and provide support. The degeneration of the discs is a natural process that can occur over time as a result of normal wear and tear on the spine. There is a strong body of evidence that shows no association between the spine degeneration seen on MRI and pain or disability. Despite this, spinal fusion surgery is still a popular treatment for degenerative disc disease. During the procedure, the surgeon removes the damaged or degenerative disc between 2 vertebrae and places a bone graft in its place. The graft can come from the patient's own body or from a donor. The bone graft is then held in place with metal hardware, such as screws or rods, which provide stability and support for the spine. Over time, the bone graft will fuse with the surrounding vertebrae, creating a solid bone. While spinal fusion surgery has been widely used to treat various spinal conditions, including degenerative disc disease, there is growing evidence that suggests its effectiveness is limited and that it may be overused in some cases. Several studies have found that spinal fusion surgery does not provide significant benefits over conservative care. A 2016 study found that patients with degenerative disc disease who underwent spinal fusion surgery had similar outcomes to those who received non-operative treatment, including physical therapy and pain management. Spinal fusion surgery has also been shown to increase stress on neighboring unfused vertebrae, accelerating degeneration in these areas. Additionally, spinal fusion surgery for degenerative conditions has been associated with significant resource utilization, with many requiring long-term therapy services and narcotic use even 2 years after surgery. The lack of evidence for the effectiveness of spinal fusion surgery raises questions regarding its use in certain cases, particularly in those with pain as the primary symptom. The American Academy of Orthopedic Surgeons recommends that spinal fusion surgery be considered only after non-surgical treatments have been exhausted, and even then, only in cases of spinal instability or severe nerve compression. Intensive physical therapy in conjunction with pharmaceutical management, including spinal injections, as well as cognitive behavioral therapy, is recommended in those who present with chronic spinal pain without neurologic symptoms. So why do these procedures that aim to fix structural causes of pain still fail? Well, it likely has to do with the fact that all of these conditions are commonly performed in those who have had chronic pain lasting months to years prior to surgery. Researchers have shown that individuals who experience chronic pain often show altered pain processing, also known as central sensitization. Central sensitization is a condition in which the nervous system becomes hypersensitive to pain signals, resulting in the amplification of pain signals and a lower pain threshold, meaning that pain responses are heightened and more easily triggered. This condition occurs when the central nervous system, which includes the brain and spinal cord, undergoes structural and functional changes in response to repeated or persistent pain. This can cause pain to be experienced even in response to non-painful stimuli, such as touch, pressure, or movement. Central sensitization has been shown to be prevalent in many individuals with these common chronic musculoskeletal pain conditions, which may explain why these surgeries are unsuccessful, as they do not address the underlying pain processing issue. To recap, our understanding of orthopedic conditions and their management is constantly evolving, and as new evidence emerges, our approach to treatment shifts to reflect the latest findings. However, despite the evidence, it can take years for clinical practice patterns to change, resulting in periods of time where ineffective procedures continue to be performed. While some of these procedures may offer short-term relief, there is no evidence to suggest that they offer long-term advantages compared to non-surgical options, not to mention their increased risk and costs. And based on the high prevalence of altered pain processing in many individuals with these often chronic conditions, understanding central sensitization is important for developing an effective pain management strategy and requires a more comprehensive treatment approach that goes well beyond simply cleaning out or fusing joints. Thanks for watching another episode of Physio Show. Make sure you like and subscribe to the channel to receive more physical therapy related content.